As Neil said, I'm Jo. My role is as a perinatal mental health training and service development lead. The Tavistock and Portman is a specialist mental health trust, but it's also a higher education provider. And we provide lots of training, both nationally and internationally, for all types of disciplines. We offer a variety of education and training programs, including postgraduate degrees, CPD courses, and tailored training for a range of professionals. So my background is actually adult mental health, and before moving into training and education, I set up and managed a specialist perinatal parent-infant mental health service, which was in northeast London. And I used to work, you mentioned in my title as clinical lead, that role's finished, but I used to work both with the London mental health team in supporting the expansion of perinatal mental health services, and also I was clinical lead with the London Maternity regional team for a little while. So I'm going to talk about what we need to know about perinatal mental health and why perinatal mental health training is important. And then I'll tell you a little bit about some of the courses that we run at the Tavistock and Portman. It's really important to remember that the detail of what you need to know, and therefore the competencies you need to develop, differ according to your role, to your profession, and the type of service that you work in. So for example, if you're a community midwife, what you need to know is different to if you're a specialist perinatal midwife. And I just wanted to say throughout this presentation, I'll refer to women and birthing people, other than at some points where the things are just specific to women. So firstly, training is important because mental health problems are really common. They affect up to 20% of women in the perinatal period. And when we talk about the perinatal period, this includes the time from when women and birthing people start to plan a pregnancy, try to conceive throughout pregnancy to the end of the first postnatal year. This means that you'll be seeing women and birthing people who either have or are at risk of perinatal mental health problems. It's important to understand the mental health problems which are specific to the perinatal period. It's not all just about postnatal depression. There are a number of different mental health problems that can specifically affect women and birthing people in the perinatal period, ranging from depression to anxiety disorders, and which can range in severity to postpartum psychosis, which we actually call a psychiatric emergency, and one of the most severe illnesses we see within psychiatry. Understanding some of the symptoms of these illnesses and why some women and birthing people may be at particular risk of developing them means that we are more likely to be able to identify them and help them to give the care they need as early as possible. So women and birthing people in the perinatal period can have a range of other mental health problems, which may have been illnesses that they had a long time before they even thought about trying to have a baby. If we talk to these women and birthing people before they want to get pregnant, we can assure that they know about any risk they have of becoming unwell in pregnancy or after having a baby, and how their illness or medication may affect their pregnancy. If GPs and other professionals understand some of these issues, they can refer for preconception appointments with a perinatal psychiatrist in a specialist perinatal mental health service, so that women and birthing people can receive advice about their treatment and be as well as possible before they become pregnant. Many different professionals can also talk to women about contraception and pregnancy planning. We know that women with severe mental illness have high rates of unplanned pregnancies. So when they get pregnant, we need to know who should be referred to perinatal mental health services or which other services may be appropriate for them to ensure access to the care that's right for them at the earliest possible opportunity. There's often a lot of complexity, as many women and birthing people can have more than one diagnosis. And of course, another reason why we all need to know about perinatal mental health and receive training is because there are specific risks associated with perinatal mental health problems, and I'm going to talk about a few of these. As has been mentioned already today, unfortunately every year women still die by suicide in the perinatal period in the UK, and many of these deaths are potentially preventable. Women in the perinatal period have a unique suicide profile, and some women who may not be considered at risk at other times are at risk of suicide in the perinatal period. Women are more likely to use violent suicide methods, such as jumping from a height or under a train, and clearly can have serious suicidal intent. And in the most recent Embrace report that was just published earlier this month, which covered from 2021 to 2023, suicides were still the most common cause of maternal death in the period between 6 weeks and 1 year after pregnancy. And mental health conditions as a whole account for over a third of the deaths during this period. It's pretty sobering. There are many lessons we can learn from the confidential inquiries into maternal deaths in the UK, and these reports emphasise the importance of perinatal mental health training for all involved professionals. And as we know, women also have a high risk of domestic abuse in pregnancy, and it's important that we are aware that this risk is even higher in women with perinatal mental illnesses, and that you know what to do about this. There are also specific risks to children associated with parental mental illness, and this is even higher when combined with other risk factors such as domestic abuse, substance misuse, and poverty. So, we all need to know when to be concerned about the risk to children, how to talk to women and birthing people about these concerns, and when to make a referral to children's social care. But equally, it's important to know that not everyone with perinatal mental health problems needs to be referred to children's social care. There are also many other risks. Some women and birthing people have a high risk of relapse. Those who stop their medication often have a high risk of relapse, so it's important to know when this may and may not be appropriate. Some medication, for example sodium valproate, presents a high risk to the developing fetus and needs to be avoided in pregnancy. There are risks associated with smoking, substance misuse and alcohol, which are all more common in people with mental health problems. Some mental illnesses are associated with an increased risk of obstetric complications, and partners are also at risk of mental health problems, and perinatal mental health problems can of course have a negative effect upon relationships. We have a real opportunity to prevent women and birthing people getting unwell, to ensure they have treatment promptly if they are ill, and to reduce risks for them and their children if they're referred to specialist perinatal mental health services early. So, for example, a woman with bipolar disorder is at high risk of postpartum psychosis and postnatal depression. So if they're referred early, we can ensure that they have a plan to reduce their risk of becoming unwell, both antenatally and postnatally. Women and birthing people who stop antidepressants and have a history of severe depression have a high risk of relapse. Being referred for advice about treatment at an early stage in preconception or in early pregnancy can really help. Ensuring women and birthing people have the right treatment and support can mean a reduction in risk to children, and that we can help them and their families have a much better experience of early family life. There are lots of reasons why women and birthing people don't get the care and treatment they need. So it's important to know why women and birthing people may not disclose their current or previous mental health problems. There can be many reasons for this, including stigma, fear that their baby will be removed from their care, or assumptions that what they are experiencing is normal in pregnancy or after birth. So this can mean without training, we may lack knowledge, confidence and skills to ask the right questions, or to know where to refer, or what to do at the right time. Even if there is a perinatal mental health service in your area that you're working, not all women and birthing people will meet criteria, and even those who do will still need to talk to you and will want to ask you questions about their mental health. Partners and other family members may also ask you questions. These may be about their illness, about available services and treatments, or about their concerns about how their illness may affect their pregnancy or their relationship with their baby. Women and birthing people may not volunteer or want to disclose their mental health history unless they're asked. NICE guidelines for antenatal and postnatal mental health care make specific recommendations about midwives routinely asking screening questions at specific time points in the antenatal and postnatal period, and this should be part of a discussion about mental health. And studies have shown that without training about perinatal mental illness and an understanding of local pathways, staff can lack confidence, knowledge and skills to do this. So, it's really important to understand not just the national guidance, but also to know about how your local pathways work. You need to know about specialist assessment and how it works in your local perinatal mental health team, how women can access emergency assessment, what psychological therapies may be available, and importantly, that if a woman or birthing person needs psychiatric admission, they can be admitted to a specialist mother and baby unit. Excuse me. So you need to know what's available in your local area in both primary and secondary care, including talking therapies, perinatal and parent-infant services, and of course to know about what's offered locally by your third sector organisations. As I've already mentioned, women and birthing people can have many different mental health problems in the perinatal period. They may have pre-existing mental illness, or they may become unwell for the first time. Not everyone needs to know all of the detail, and you certainly don't need to be able to make a diagnosis, but all professionals do need to have a basic understanding of mental disorders to consider the effect on an individual woman's or birthing person's functioning and what the implications may be for parenting and for potential associated risks. So, for example, if you're seeing someone who has a diagnosis of schizophrenia or someone with a personality disorder, it's good to know some basic knowledge of what these illnesses are like, how they may affect the woman or birthing person, and the potential impact on their parenting capacity. We also need to know why it's important to understand each individual woman's or birthing person's context and history, and how this can affect their experience of the perinatal period. For example, if there's stigma about mental illness in their culture, or if their partner or family has a very negative attitude to mental illness, it may be harder for them to engage with services. If they've had an abusive childhood and have not had a good experience of being parented themselves, they may have a lot of difficult memories that can resurface in the perinatal period and may not have an understanding of what good parenting looks like. Understanding these various issues can help to ensure that women and birthing people receive the individualised care that they need. And we also importantly need to consider women and birthing people's experience of things such as fertility treatment, of pregnancy complications, of having a diagnosis of a fetal abnormality, or of having a traumatic birth. It's also important to understand each woman or birthing person's and partner's experience of the transition to parenthood and life with a baby. And it's really important to know how mental health problems can affect the baby and the parent-infant relationship, and to think about things like bonding and attachment. And of course, it's also important to learn about partners. from the point of view of being a carer for a person who has a perinatal mental illness and understanding the risk of a partner developing their own mental health problems and how these difficulties can affect the couple's relationship, their relationship with their baby, and with other children. It's really important to have an understanding of the barriers to accessing care and treatment, some of which I've already mentioned, and what can help women and birthing people and families to engage in treatment and in care. And joint working and good communication are a really fundamental part of good perinatal mental health care. There are often so many professionals and services involved, and there can be a lot of complexity. It's important that through training all professionals understand the importance of partnership working, of good communication, and of your role within the system. Often when serious incidents occur, it's a lack of communication and lack of clarity about roles that's highlighted. Finally, referring into a perinatal mental health service, you need to know something about what treatments that service offers, so that when you make the referral, you can explain this to the woman or birthing person, and to know whether to refer to talking therapies or into the specialist service. It's also important to know that women and birthing people should not be told to just stop their medication. It's really important that they have a discussion about the risks and the benefits of treatment. So I hope that this has provided a bit of background. I know I've talked very quickly and covered quite a lot of different things, but really just wanted to talk about why perinatal mental health training is so important, not only for midwives, but for all professionals. And so, as I mentioned, at the Tavistock and Portman, we offer a whole range of CPD and postgraduate training aimed at all different professionals. Our training seeks to ensure that professionals have the skills, the competencies, and the expertise needed to support women and birthing people experiencing mental illness during the perinatal period. And in terms of perinatal mental health training, which are amongst lots and lots of courses that the Tavistock and Portman offer, there are several courses that are available, and it's really important to pick the right course for you at the right time. A lot of our training is online, so it's easy to access. You don't need to travel down to London to come and see us. Some of it can be done at any time, and some of it's done as live online training. So specifically to perinatal mental health, we have a little brief introduction course. It's just a short course, which is online. We have a longer online course, which goes into more detail in terms of perinatal mental health, risk care and treatment. We also run across the UK a perinatal mental health postgraduate module. So this module is specifically for perinatal mental health midwives, perinatal health visitors, and specialist perinatal practitioners. It's a 20-week online postgraduate module, which is validated by Essex University and awards 30 credits. And we run it twice a year. And if you're looking to do something at a higher level of training, the Tavistock runs a course that's sort of known as M7, but the longer title is Perinatal Child, Adolescent and Family Work. So that's much more of a psychodynamic, observational 2 years master. And that's run at various places around the country. But if you just want to dip in and out of things and just sort of top up your knowledge about perinatal mental health, we have a monthly perinatal lecture series. So lots of different speakers come to talk about perinatal mental health. But it's good to think about babies and young children as well. And if you're particularly interested in this, we've got a 12-week infant observation course, which looks at how infant observation can be used within clinical work. And then we've got a couple of shorter courses that focus on child and brain development, attachment theories, and nature versus nurture. Or you can do them together in this a bundle of 3 courses called Understanding and Nurturing Troubled Children. And just before I finish, I wanted to tell you a little bit about our trauma courses. trauma is an area that Tavistock specialises in, and we've got a whole variety of courses, but I've just put 3 here that you may be interested in. So there's an introductory online course about trauma and neglect and building resilience, a course that focuses on trauma-informed care that goes into more detail, and then a longer, more in-depth course that looks at the theory and practice of trauma. And finally, something that we've been asked to do quite a lot, and we've been asked by various different organisations to run bespoke training, has been looking at reflective clinical supervision, how to embed that within practice. And we're very, very happy to think with organisations about bespoke training offers. So that's me, really. All of the courses that I mentioned can be found on the website. This is the links, and got lots of leaflets. I don't really want to take them all back on the train, so please take one if you haven't already got one. That's my email address if you want to get in contact, if you want to have a chat about things, and I'll be here for a little bit longer this afternoon as well in the stands. Thank you.
Okay. So a chance for questions now. There's a microphone there so that the people at home, if there's any questions you'd like to ask Jo. I'd like to ask just about the proportions of these things. I mean, people have always talked about post-natal depression and the baby blues. What is likely to be regular and manageable compared to what is serious clinical, perhaps pre-diagnosed?
Yeah.
I mean, what's the scales in all of these things? Are you able to say?
I mean, it's 1 in 5. So 1 in 5 women will experience mental health problem during the perinatal period. The range of those. So there was a little diagram a little bit further back. God, technology is good, isn't it? So this diagram. So this shows the range of things. So things like postpartum psychosis is much rarer. You may, during your career see a couple of women with postpartum psychosis, whereas those that experience more severe depression or anxiety is much commoner. And these are some of the figures. So we're all going to come across women, all different ranges. Some are going to have more severe mental health problems, but there's going to be lots and lots of women that you come into contact with that have got the more sort of mild to moderate mental health presentations.
Okay. Questions from the floor? Judith?
Thank you.
Say where you're from.
Oh, hi, so I'm Judith Cutter and I'm a consultant midwife in Cardiff. I know a lot of people in the room actually. So just wanted to touch on the training. So the courses that you've been talking about, they look fantastic, and it's great that they're online as well. This is really it's great for midwives because it's really hard to get out of clinical practice to attend a course. So the fact that they're quite easily accessible is brilliant. In addition to these, do you hold any kind of support forums or online forums for midwives who maybe have accessed the courses and then are out there in practice and maybe want to reflect on some experience, or just wondering if there was an opportunity?
We have done that. So some organisations have commissioned some of the online courses in quite large numbers actually, and what we've done is we've put people into groups of cohorts. They've done the training online in their own time, but then they've come together for reflective groups afterwards, because a big focus of the training is getting people to reflect on what they're learning and how it relates to clinical practice. So we'll do some online reflection groups together. Some of those can just be one-off groups, and some of those have been sort of more continuing groups, because we don't often get that opportunity to go back and think over, perhaps some of the women that we worked with in the past, or perhaps, if we'd had this information, we would have done things differently. So we found that they worked really well. I was going to say, so within our postgraduate modules, one of the things that we introduce is something called work discussion. So people bring cases for discussion. Beauty is you get to discuss it as a multidisciplinary group of practitioners, and we have lots of midwives who say, I'm going to take that back into my practice. That's really useful. Just that opportunity to unpick and reflect on something that perhaps didn't go that well, or, you know, something where there was a difficulty, but to do that as a learning opportunity. So yeah, it's just about people taking the tools and, you know, taking them back into practice, really.
Thank you very much.
Any other questions? A quick question about trauma. In the Embrace report that's just come out, I think the C-section rate has gone up 2023 to about 43%. Every midwife I speak to says that it's already gone over 50% in their units. The Birth Trauma Association says that half of birth trauma is related to the unexpected C-section as opposed to the planned C-sections, and I think in the last figures there were about 120,000 of those. That understanding of that kind of birth trauma, that difference between the expectation during pregnancy and the outcome, who is seeing the impact of all of that?
Well, in England, as part of the 5-year forward view, and then you know, some funding that followed that, what was set up were maternal mental health services. So those services work alongside maternity services, specialist midwives, psychological practitioners, peer support workers, to work with women that have experienced a previous trauma and, you know, they're having another baby, or, you know, they've experienced trauma during this current pregnancy, or perhaps experienced a trauma, you know, removal of a baby. And those services, as they've developed, the resources have been really quite small, and they've been absolutely inundated. You know, I think the need for such services was underestimated, really. And, you know, we're finding more and more that previous trauma, you know, that perhaps has been unresolved, can resurface in, you know, in different ways, either antenatally and postnatally, and it's really important to be able to get that specialist care, particularly that psychological care. And these maternal mental health services, because they're working together alongside maternity services, offering that psychological input, is working really well. So yeah, I don't know whether that answers your question.
Well, it's part of it.
Yeah.
A quick question. I mean, society is now very much more fragmented. Women are often end up feeling quite isolated.
Yeah.
Partners are out at work. Family is far away. Compared to, I mean, I often make a point of asking women from Asian or Afro-Caribbean communities if they still have the auntie system of surrounding newborn women with the family for a period of time. And most of them say that yes, that still happens, even if they're not blood relatives. But that isolation seems to be something that possibly makes mental health even worse in a normal way. Other signs of, I mean, how do you look at these kind of changes that have happened over the past 40, 50 years?
Goodness, that's a big question.
No, the only reason I ask is that I was born into a village of a few hundred people, of which about 40 of them shared my name, and I had aunties and cousins everywhere, and still do. But that appears to have been completely exceptional. You know.
Yeah, I mean, so many women are not now giving birth in the country that they were born in, and you know, I think we've still got a long way to go in terms of stigma and making things easier to access, but also, you know, it's really important to take into consideration all those different cultural aspects, you know, cultural rituals, as you say, and to respect that. That, you know, just because this is the way that we run our mental health services, we need to be able to adapt and to accommodate that. I think, you know, we've still got a long way to go, really.
Yeah. Okay. Any final questions? One in the middle, if we just to pass on the microphone. There we go.
Hi, I'm a student midwife. Thank you for your speech. I have a question. Is when I have my placement in the community, we only know women have a mental health problem when they report it, but there are so many hidden. Like myself, I suffer from postnatal depression myself, but I never seek professional help. My question is, as like a student or a future midwife, how do you identify the symptoms when women have mental problems, mental health?
I mean, it's not a one-off. It's not a one-off thing. It's about every opportunity that you get when you're meeting with a woman to ask, to ask. And it may take a woman several times, several appointments to feel comfortable to able to disclose things. And it could, it's good to sort of practice how you may ask those questions, because you'll need to ask them in different ways to different people. And it's important to know that sometimes women will minimise, will downplay, will just like you did, just not disclose. So it's about having a little sort of repertoire, a little toolkit in terms of being able to ask questions, not to be afraid to ask about whether they've had any suicidal thoughts, whether they've had thoughts of harming themselves, etc., and to take it from there. So it's not for you to diagnose. It's not for you to need to know the whole full checklist of symptoms, but it is about having the confidence to make that woman comfortable enough to be able to talk to you about it, and then knowing, okay, this is what's happening, so I need to refer on to this service who can then provide that more specialist support.
Okay, thank you very much. Jo, that's an absolutely enormous issue. We could have gone on for ages. We could have gone on to, watching what's happening to partners, refuge, say that 30% of domestic abuse is often triggered by childbirth. The reaction of siblings, a woman coming back with an infant who already has two, is a very stressful environment, as I can testify. But no doubt we'll cover these on other occasions. So a big round of applause for Jo. Thank you very much. Okay.